So then under cardiovascular examination, murmurs. So these are sounds, no sounds that occur during systole or diastole. So why are these murmurs occurring? So because of the turbulent blood flow. So these murmurs are occurring because of the turbulent blood flow, and it falls into two broad groups. So these are sounds that occur during systole or diastole as a result of turbulent blood flow and falls into two broad groups. So leaking backwards across a valve that is supposed to be closed. So these are referred to as regurgitant or insufficiency murmurs. So what are insufficiency murmurs? So this will be there and this will be there. So this will be the mitral valve. So normally blood flows from left atrium to left ventricle, but what here happens here is there is a mitral regurgitation. So this is a regurgitant or insufficiency murmurs. And flow disturbance across a wall that will not open fully or normally. So these walls suffer from varying degree of stenosis. So there is a stenotic wall. So this example is aortic stenosis. So it is worth mentioning that sometimes flow murmurs can occur resulting from high output across structurally normal walls. Walls will be normal, but there will be a high output across structurally normal walls. So this will cause flow murmur. So why flow murmurs? High output across structurally normal walls. In addition, some walls with insignificant degrees of pathology. So some walls, no, they'll have the insignificant degree of pathology like aortic sclerosis, where the wall leaflets are slightly calcified yet function normally, so they also generate murmurs. So insignificant degrees of pathology such as aortic sclerosis, where the wall leaflets are slightly classified yet they are functioning normally, so they also generate murmurs. So distinguishing which murmurs are clinically relevant takes thought and practice. So traditionally, students are taught that auscultation is performed over the four areas of the precordium that roughly correspond to the location of the four walls of the heart. So aortic valve is there in the right second intercostal space, pulmonic valve area in the left second intercostal space, pulmonic area left second intercostal space, aortic area right second intercostal space, tricuspid area fourth left intercostal space, and mitral valve area fourth intercostal space in the mid-clavicular line. So this leads to some misperception. So valves are not strictly located in these areas, nor are the sounds created by valvular pathology restricted to those spaces. So while it may be okay to listen in only four spaces when conducting the normal exam, it is actually quite helpful to listen in many more when any abnormal sounds are detected. So if you hear a murmur, you have to ask yourself. So you are hearing a murmur, you have to ask yourself, so does it occur during systole or diastole? So it's occurring during systole or diastole. So what is the quality of the sound? So does it get louder and then softer? So does it get louder and then softer? So does it maintain the same intensity throughout? So does it maintain the same intensity or is getting louder and then softer? Does it occur during systole or diastole? Does it start loud and then become soft? And it sometimes helps to draw a pictorial representation of the sound. So we can draw a pictorial representation of the sound. So what is the quantity of the sound? So the rating system is 1, can only be heard with careful listening. Only if we carefully listen, then it is called as grade 1. Okay, readily audible as soon as the stethoscope is applied to the chest. So as soon as you put the stethoscope, so it is 2/6. 3/6 is louder than 2/6. 4/6 means it's accompanied by a thrill. Thrill is there means it is 4th grade. Okay, 3/6 means louder than 2/6. So 5/6 audible even only when the edge of the stethoscope touches the chest, and 6/6 means audible even to the naked ear. Only the edge of the stethoscope touches the chest. So it is 5 by 6. 6 by 6 means audible to the naked ear. So most murmurs are between 1 by 6 and 3 by 6. So most murmurs between 1 to 3 by 6. Louder generally but not always indicates greater pathology. If it is louder, it generally indicates a greater pathology. So what is the relationship of the murmur to S1 and S2? So what is the relation to S1 and S2? When does it stop and when does it stop? So what happens when you march your stethoscope from the right second intercostal space out towards the axilla, the mitral area? So you're marching your stethoscope from second right intercostal space, the aortic area, towards the axilla, so the mitral area. So where is it loudest and in what directions does it radiate? So by moving in small increments, that is listening in 8 or 10 places along the chest wall, you will be more likely to detect changes in the character of a particular murmur and thus have a better chance of determining which valve is affected and by what type of lesion. So if you move in small increments, no, that is listening in 8 or 10 places along the chest wall, you will more likely to detect changes in the character of a particular murmur and thus have a better chance of determining which valve is affected and what is the type of the lesion. So you have to move in small increments. So 8 or 10 spaces along the chest wall. And auscultation over the carotid arteries. In the absence of murmur suggestive of aortic valvular disease, you can listen for carotid bruit. That is, carotid bruit is nothing but sounds created by turbulent blood flow within the blood vessel at this point in the exam. So how do you look for carotid bruit? So place the diaphragm gently over. So you are placing the diaphragm gently over each carotid and then you are listening for a soft high pitched shing sound. So what sound you are listening over the carotid? Soft sound, high pitched and shing sound. So it is helpful if the patient can hold their breath as you listen so that you are not distracted by transmitted tracheal sounds. So sometimes you get disturbed, like whether it is a tracheal sound or whether it is a soft high pitched shing sound of carotid. So then you have to tell the patient to hold their breath. The meaning of a bruit remains somewhat controversial. I was taught that bruits represented turbulent flow associated with intrinsic atherosclerotic disease, and that the disappearance of a bruit which was previously present was a sign that lesion was progressing. However, a number of studies provide evidence that atherosclerotic disease is frequently absent when a bruit is present, as well as the reverse situation. This is actually of clinical importance because recent data suggests that it may be beneficial to surgically repair carotid disease in patients who have significant stenosis yet have not experienced any symptoms like TIA or stroke. Surgery in these settings has already proven to be beneficial. So thus it becomes increasingly important to determine the best way of identifying asymptomatic carotid artery disease, and carotid auscultation may in fact not be the mechanism of choice. Okay. And then systolic murmurs. So in the adult population, so these generally represent either aortic stenosis or mitral regurgitation. So to distinguish them, remember the following. So murmur of aortic stenosis. Systolic murmur means you have to remember two conditions. So one is aortic stenosis and the other is mitral regurgitation. So aortic stenosis, no, they tend to be loudest along the upper sternal borders and get softer as you move down and out towards the axilla. So aortic stenosis, no, this murmur is loudest in the upper sternal border, and as you move down and out towards the axilla, no, it gets softer. Okay, so when you are hearing the loudest murmur on the upper sternal border, and you move down and out towards the axilla, it is getting softer. So there is, however, a phenomenon known as the Galaverdin effect, okay, which can cause murmurs of AS to sound as loud towards axilla as they do over the aortic region. So another thing we have is Galaverdin effect, in which aortic stenosis murmur will be there, but it will be as loud as it is in the aortic region, in the axilla. So when this occurs, the shape of the sound should be similar in both regions, helping you to distinguish it from mitral regurgitation. So the shape, so when this occurs, no, when that aortic stenosis murmur, it is loud in the axilla, generally it becomes softer, no. So this is called as when the same loudness, if it is there even in the mitral area, then we have to think of Galaverdin effect, to sound as loud towards axilla as they do over the aortic region. So when this occurs, the shape of the sound should be similar in both regions, helping you to distinguish it from mitral regurgitation, and having a growling harsh quality. So what happens in aortic stenosis murmur? It has got a growling and it has got a harsh quality, that is get louder and then softer. So also referred to as crescendo decrescendo systolic ejection or diamond shaped murmur. So early peaking murmur of aortic stenosis, it has got a growling harsh quality, that is getting louder and then softer. So this is called as crescendo decrescendo systolic ejection or diamond shaped murmur. So where you get this diamond shaped murmur? In aortic stenosis. It's a growling harsh quality, louder and then softer, also referred to as crescendo decrescendo systolic ejection or diamond shaped murmur. So when the stenosis becomes more severe, the murmur is loudest, that is its peak intensity occur later in systole, as it takes longer to generate the higher ventricular pressure required to push blood through the tight orifice. So if stenosis has become more severe, so then what will happen is, normally it is a diamond shaped murmur, but when the stenosis becomes severe, but the point at which murmur is loudest, that is its peak intensity, it will occur. So this is systole only, no. So this is occurring later in the systole, because it takes longer to generate the high ventricular pressure required blood through push blood through the tight orifice will be there. So to push the blood through this valvular area, so it will require higher pressure, and are better heard when the patient sits up and exhales. So when do you hear this murmur better up? When the patient is sitting up and he is exhaling, okay, exhaling. So are heard in the carotid arteries and over the right clavicle. So this murmur, it is also heard in the carotid arteries and over the right clavicle. So radiation to the clavicle can be appreciated by simply resting the diaphragm on the right clavicle. So how to know that patient has got radiation? Just put the diaphragm on the right clavicle, so then we can appreciate that murmur is radiating to the clavicle. To assess for transmission to the carotids, have the patient hold their breath while you listen over each arteries using the diaphragm of your stethoscope. So for transmission to the carotids, tell the patient to hold their breath, and you will examine each artery using the diaphragm. So carotid bruits can be confused with the radiating murmur of aortic stenosis. So carotid bruit and even aortic stenosis murmur, no. So this also radiates to the carotid. So in general, carotid bruits are softer, okay. So carotid bruits are softer, and also murmurs associated with aortic pathology should be audible in both carotids. So murmurs, no, associated with aortic pathology, they should be audible in both carotids and get louder as you move down the vessel towards the chest. So both carotids, the murmur, if it is of aortic pathology, it should be audible. Whereas in carotid bruit, only one vessel, okay? And as you move down from the vessels towards the chest, no, it will get louder. So in settings where carotid pathology coexists with aortic stenosis, carotid pathology is there and it is coexisting with aortic stenosis. So a loud transmitted murmur associated with a valvular lesion, no, it may overwhelm any sound caused by intrinsic carotid disease, making it completely. Carotid upstrokes refer to the quantity and timing of blood flow into the. So carotid upstroke means it refers to the quantity and timing of blood flow into the carotids from the left ventricle. So they can be affected by aortic stenosis and must be assessed whenever you hear a murmur that could be consistent with aortic stenosis. So this is done by placing your fingers on the carotid artery as described above while you simultaneously listen over the chest. And there should be no delay between the onset of the murmur, which marks the beginning of systole, and when you feel the pulsation in the carotid. So in the setting of critical, that is very severe aortic stenosis, small amounts of blood will be ejected into the carotid, and there will be a lag between when you hear the murmur and feel the impulse. So carotid upstroke means it referred to the quantity and timing of blood flow into the carotids from the left ventricle. So from the left ventricle, upstroke means quantity and timing of blood. So they can be affected by aortic stenosis and must be assessed whenever you hear a murmur that could be consistent with aortic stenosis. So how to assess this? By placing your fingers on the carotid artery as described above while you simultaneously listen over the chest. So you are listening over the chest and you are placing your fingers on the carotid artery. So there should be no delay between the onset of the murmur, which marks the beginning of systole, and when you feel the pulsation in the carotid. So there should be no delay between the onset of the murmur, which marks the beginning of systole, and when you feel the pulsation in the carotid. So in the setting of critical, that is very severe aortic stenosis. So what happens in very severe aortic stenosis? Small amounts of blood will be ejected into the carotid. Small amounts of blood, no, it will be ejected into the carotid, and there will be a lag between when you hear the murmur and feel the impulse. So this is referred to as diminished and delayed upstrokes. So diminished and delayed upstrokes, so as opposed to the full and prompt inflow which occurs in the absence of disease. Mild or moderate stenosis does not alter the character of the carotid inflow. So mild or moderate stenosis does not alter the character of the carotid inflow. And subaortic stenosis means it's a relatively rare condition. So this is about carotid upstroke, and this is subaortic stenosis, rare condition. So why the subaortic stenosis? It is due to obstruction of flow from the left ventricle into the aorta. It is caused by ingrowth of septal tissue in the region below the aortic wall, known as the aortic outflow tract. So in the aortic outflow tract, there is a ingrowth of septal tissue in the region. So it causes a crescendo decrescendo murmur that sounds just like aortic stenosis. So it causes a decrescendo murmur. So this is also sounding like aortic stenosis. So as opposed to aortic stenosis, however, the murmur is louder along the left lower sternal border and out towards the apex. So how is the murmur? It is louder along the left lower sternal border and out towards the apex. So this makes anatomic sense as the obstruction is located near this region. So this makes anatomic sense as the obstruction is located near this region. It also does not radiate loudly to the carotids as the point of obstruction is further from these vessels in comparison with the aortic valve. It also does not radiate loudly to the carotids because the point of obstruction is further from these vessels in comparison with the aortic valve, and you may also be able to palpate a Bispherians pulse in the carotid artery. Okay, also so Bispherians pulse, it is seen in aortic insufficiency. Furthermore, the murmur will get softer if the ventricle is filled with more blood, as filling pushes the abnormal septum away from the opposite wall, decreasing the amount of obstruction. Conversely, it gets louder if filling is decreased. So this phenomenon can actually be detected on physical exam and is a useful way of distinguishing between aortic stenosis and subaortic obstruction. Ask a patient to Valsalva while you listen. So if you do a Valsalva, what is happening is this decreases venous return and makes the murmur louder, and will have the opposite effect on a murmur of aortic stenosis. So to hear the subaortic stenosis murmur, so ask the patient to do a Valsalva while you listen. So because when you do a Valsalva, so this decreases venous return and it makes the murmur louder, and it will have the opposite effect on a murmur of aortic stenosis. Then again while listening, squat down with the patient. So this manner, it increases venous return, causes the murmur to become softer. Standing will cause the opposite to occur. So you need to listen for 20 seconds or so after each change in position. So after each change in position, you need to listen for 20 seconds to really appreciate any difference. Ask a patient to Valsalva. So this Valsalva, so this decreases the venous return and it will make the murmur louder and will have the opposite effect on the murmur of aortic stenosis. Then again while listening, squat down with the patient. So this manner, squatting down, it increases the venous return. Okay, Valsalva, it is decreasing the venous return. Squatting is increasing the venous return. So this is causing the murmur to become softer. So standing will cause the opposite effect, opposite to occur. So you need to listen to for 20 seconds or so after each change in position to really appreciate any difference. So because the degree of obstruction can vary with the ventricular filling, so degree of obstruction, no? So this will vary with the ventricular filling. Subaortic stenosis is referred to as dynamic outflow tract obstruction. Subaortic stenosis, it is referred to as dynamic outflow tract obstruction. In aortic stenosis, the degree of obstruction that exists at any given point in time is fixed. In aortic stenosis, the degree of obstruction that exists at any given point in time is fixed.